Well, good morning, everybody. My name is Jordan Dozier. I am a thoracic surgeon here at Ochsner, um, here in New Orleans, and this is my third year involved with CAGLA. I started out in 2023. I was 6 months into my career, and my senior partner kind of told me that I was going to be presenting here at CAGLA, but I jumped at the opportunity. It was one of the better decisions that I've made. This is a excellent organization, and whose heart is truly in the right place, and committed to uh, taking care of cancer patients here in Louisiana. So, um, with that being said, welcome everybody to the lung block of the fourth annual CAGLA conference. Most of us in this room already know that lung cancer remains one of the most deadly cancers in the world, not just in Louisiana. And overall, we have made a significant strides in treating lung cancer. But we still have a ways to go. And the best way to attack this is in a multidisciplinary team approach. And so that's kind of how we're going to approach today's talks, with a couple of talks that range from early stage to late stage disease. So we'll start with lung cancer screening. Then we'll talk about some of the systemic therapy, chemotherapy, and how that's combined with surgery. And then finally, we'll end with a talk on surgery outcomes following chemotherapy in a neoadjuvant setting. So, with that said, let's get started. Our first speaker is Dr. Robert Merritt. Um, I prefer my training at Ohio State, and so Dr. Merritt is not just my past boss. He is a colleague, a mentor, and a friend. And I'm really happy that he is able to join us here today. He completed his medical school at Cornell, residency at New York Presbyterian, and fellowship at Harvard. So a couple of good schools in there. He is currently a professor of surgery and director of the thoracic division at Ohio State. Uh, Under his leadership, the division earned a distinguished three-star designation in both lung cancer resection as well as esophagectomy. And Dr. Merritt's dedication to improving patient outcomes through innovative surgical approaches and his extensive research in thoracic oncology make him a leading authority in lung cancer screening and treatment. And so please join me in welcoming Dr. Merritt.
Good morning, everyone. It's an honor to be here today to give this talk. I just want to thank Dr. Dozier for the kind invitation to present here today at CAGLA. And I'm happy to see he's flourishing and doing well here in New Orleans. I'm going to talk about lung cancer screening. Usually I give a talk about surgery for early stage lung cancer. But without early detection, most patients that we see have stage 3 and 4 lung cancer. And as you can imagine, once lung cancer presents at that later stage, it's very difficult to offer patients cure. If you look at breast cancer, colon cancer, with mammography, colonoscopy, these diseases are detected at much earlier stages. And as a result, the results in terms of overall survival and cancer-specific survival is a lot better. So we do have lung cancer screening, which is a new tool that we can use to detect these cancers earlier. But in order for it to work and to get the benefit, we have to use it. So I'm going to address some of the issues that we're facing. So lung cancer, as was stated earlier by Dr. Dozier, is a very lethal cancer. It's certainly diagnosed at much later stages. And if you look at mortality rates comparative to other solid organ tumors, we're not doing great in curing lung cancer here in the United States or really any other country. Early detection is very critical to diagnosing these patients at a much earlier rate. And this is really the only way that we're going to make an impact in decreasing mortality-specific cancer rates for lung cancer. Also, we have to address cigarette smoking and smoking cessation. Cigarette smoking is the number one risk factor for small cell and non-small cell lung cancer. So not only do we have to screen patients, but we also have to decrease cigarette smoking rates in the country. We have a great tool for doing screening for lung cancer. Low-dose radiation CT scans were introduced years ago and are very effective and far more effective than chest x-rays and sputum cytologies in detecting small, early-stage peripheral non-small cell lung cancers. And the key here is that we're getting these patients in the preclinical stage and also when they're asymptomatic, because that's when we're really going to make the most impact. And if we diagnose them at an earlier rate, we can offer curative surgery and other local modalities to treat the cancer. So why is it important? So as I just stated earlier, early detection really is the only way that we're going to significantly improve lung cancer-specific mortality rates. Patients usually present symptomatic when the lung cancer is spread, and there's really no hope for a cure. So that's why screening is an important tool for us to utilize. We clearly know who should be screened. The U.S. Preventative Services Task Force issued the criteria for lung cancer screening. So I'll just go over that briefly. So patients age 50 to 80 with a smoking history of 20 pack years, and current smokers or those who quit within 15 years. So we have clear guidelines. So these are patients who qualify for lung cancer screening. It's covered by Medicare and most insurance companies based on the data that I will present soon. So we clearly have identified a high-risk cohort of patients who qualify for lung cancer screening, but yet the tool is woefully underutilized in the United States. And I'll go over some numbers later. So the benefits are clear. You know, if we detect cancer early, we have a higher chance of curing the cancer, and we get better overall survival. So those are the clear benefits of lung cancer screening, and we have clearly a high-risk cohort that would benefit most from this tool. So I'm just going to go over the history of lung cancer screening because recently it's become more popular. We have more awareness, but in the early years, in the 60s and 70s, all we really had was chest x-rays and sputum cytology. And as you can imagine from the initial screening studies, x-rays and sputum cytology did not really diagnose early stage lung cancer. The patients that were detected had large central tumors involving the airway. So these were easily detected on chest x-ray and sputum cytology. But what about the peripheral 1 centimeter adenocarcinoma? That's unlikely to be detected by sputum cytology or chest x-ray. So we needed some more advanced imaging modalities in order to detect these smaller, earlier stage tumors. So with the introduction of a low-dose computed tomography, a low-dose CT scan, we were able to detect smaller peripheral lung nodules that could represent early stage lung cancers much more effectively than a chest x-ray or sputum cytology. The radiation dose for these imaging studies is very minimal, 1.5 millisieverts, which is 3 to 4 times less than a standard diagnostic CT. So very low dose of radiation, very effective in detecting small peripheral lung nodules. So really the first clinical trial that tried to determine if lung cancer screening was even beneficial. So the first was the International Early Lung Cancer Action Program, or LCAP. And really, this study demonstrated that low-dose CT scans could effectively diagnose small peripheral lung cancers much better than a chest x-ray. But unfortunately, this study was not set up to determine if it would impact the mortality rate from lung cancer. But we did get some useful information from this study that low-dose CT scans are far superior than chest x-rays for detecting small peripheral lung cancers. So really, the National Lung Cancer Screening Trial, which I'll go over in detail a bit later, was really the first randomized clinical trial which confirmed that the mortality could be reduced with low-dose CT scans for early stage lung cancer. And then in 2020, we had a 10-year study from the Dutch-Belgian randomized clinical trial, or NELSON, which confirmed that low-dose CT scans can lower cancer-specific or lung cancer-specific mortality with low-dose CT scans for lung cancer screening. So as a result, the U.S. Preventative Services Task Force guidelines in 2021 slightly changed their eligibility criteria for screening based on the results of these two positive randomized clinical trials, which demonstrated a clear benefit for low-dose CT scan usage for lung cancer screening. So I'll go over the National Lung Cancer Screening Trial briefly. So it was a randomized clinical trial. It included over 53,000 patients with a heavy smoking history. Patients were randomized to a low-dose helical CT scan or a standard chest X-ray. At the end of the analysis of the study, there was a 15 to 20% reduction in lung cancer mortality with low-dose CT scans compared to chest X-ray. In addition, the all-cause mortality was reduced by 6.7% by the use of low-dose CT for lung cancer screening. So this demonstrated a clear superiority for low-dose CT in lung cancer screening. Also, the guidelines for screening were impacted by this study. So this was a very important landmark study, which really supports the benefits of lung cancer screening. And this is the sort of results of the trial. So if you look at the top graph, low-dose CT scans clearly detect more early-stage lung cancers than chest X-rays alone. And if you look at the bottom, the cumulative lung cancer death rate was much lower in patients who underwent low-dose CT scan compared to a chest X-ray for lung cancer screening. And the study was published in the New England Journal of Medicine in 2011. So this is the Nelson trial from the Netherlands and from the Belgian population. And in this study, it was a slightly different study design. So patients were randomized to low-dose CT scan or nothing. So the control group was not screened at all. And this was also a 10-year follow-up period. So a far longer follow-up period than the National Lung Cancer Screening Trial. So if you look at the results, there was a 24% reduction in lung cancer mortality among men and a 33% reduction in lung cancer mortality among women. And this was a long-term follow-up, 10-year follow-up period. So this validated the results that were determined from the National Lung Cancer Screening Trial, and it reinforced the importance of lung cancer screening in a high-risk, highly selected population of smokers. So this further galvanized the movement to actually recommend and utilize lung cancer screening for these high-risk patients. So these are the results of the study. So if you look in the first graph, the screening group had clearly more lung cancers detected. And then in terms of their lung cancer-related mortality, far superior in the patients who were screened. So again, this validated the importance of low-dose CT scans for screening. So how do we manage lung nodules that are detected? So one of the criticisms of lung cancer screening is that you're going to detect a lot of small lung nodules. In the National Lung Cancer Screening Trial, any lung nodule over 4 millimeters was considered positive. So as we know from our practices, we don't really get concerned about lung nodules that small, and we're not going to biopsy every 4 millimeter lung nodule. Once it reaches 1 centimeter, has certain characteristics, speculation, growth, petavidity is when we would usually seek a resection or a biopsy followed by a resection. So there needed to be a more discerning tool to utilize to determine which nodules are suspicious and which ones we should go after in biopsy. So the LungRad system was developed as a tool to standardize lung cancer screening CT reporting. It's very similar to the process that's used for mammography. So the classifications are based on the characteristics of the lung nodule, such as size, attenuation, and increase in size over time. So a lung RADS of 1 to 2 is usually low risk and doesn't really require biopsy, just a very regimented follow-up regimen for the patients. So these are low-risk nodules that we're not really concerned about. But when you get to the lung RADS 4, particularly 4B, these are lung nodules that are spiculated, over a centimeter in size, most likely found in a smoker, and there's clear evidence of growth. So these are clearly high-risk lung cancers that should be biopsied and treated as well. So the lung RADs really added a more way to discern which nodules are high risk and which ones need to be biopsied and treated. So there are potential harms to lung cancer screening. So there's a risk of overdiagnosis. You will detect lots of lung nodules which have no clinical relevance. There'll be detection of benign lung nodules which don't require treatment, and also lung nodules that may appear to be high risk but may actually be granulomas or benign. So this does result in unnecessary biopsies, which have potential complications, which could harm patients. So this is why it's very important to use the lung RAD system, and hopefully in the future more diagnostic modalities to really determine which lung nodules are high risk. And if you look at the National Lung Cancer Screening Trial, 96% of the patients had a positive result because their criteria was not very discerning. 4 millimeter lung nodule is in most cases going to be benign. So it's why it's important to utilize things like lung RADs to really determine which lung nodule is high risk and what needs to be biopsied. And it's really it's important to note that many of the surgical resections that are performed in patients that are screened turn out to be benign. So that's what we want to avoid. We want to avoid unnecessary biopsies on low-risk lung nodules and avoid surgeries and other treatments for benign lung nodules. So as a result of this trepidation to utilize this tool, due to the potential harms of patients, there's been a very slow uptake of lung cancer screening in the United States. As of 2022, only 21% of eligible individuals, based on the guidelines that I showed you earlier, underwent lung cancer screening. So a large cohort of high-risk patients who would benefit from lung cancer screening are not getting the modality for many reasons, but primarily bias in some primary care physicians who think that it might introduce harm rather than offer a benefit. So this is why it's important to set up a very comprehensive lung cancer screening program that includes shared decision-making between patients and physicians and providers. And this will provide a framework by which patients who have high-risk lung nodules can safely be evaluated, and if they have high-risk lung nodules, they can certainly be biopsied. But it's important that we overcome these barriers because this is clearly a beneficial tool for high-risk patients who are smokers. The earlier we detect lung cancers, the better chance we have of curing these patients. So really, this is a public health issue and should be a public health priority. And as physicians, providers, nurses, anyone involved in lung cancer care, particularly treatment of lung cancer, we should become champions for lung cancer screening and improve these woeful uptake rates for lung cancer screening. So I think in terms of gaining acceptance for lung cancer screening, it's important to increase the public awareness, particularly in smokers, of the risk of lung cancer and also the dangers if it's detected at a later stage, and clearly amplify the benefits of detecting lung cancer in stage 1 as opposed to stage 3 or stage 4. Also, we need to change the perception of lung cancer screening and not overemphasize the potential harms. If we use good technologies and good processes, and we have organized lung cancer screening programs, we can clearly identify high-risk patients and avoid overdiagnosis and harm to patients by clearly identifying who would benefit most from lung cancer screening. So this will require efforts from cancer centers and other health organizations to promote lung cancer screening and to overcome the barriers of acceptance. Obviously, there's a lot of stigma and fear in lung cancer patients or patients at risk for lung cancer due to smoking. But again, these are the patients that are going to benefit the most from screening. So we need to overcome that barrier. And the way to do that is through education and elevating awareness of the benefits. The other issue is access and availability. Very few centers have organized lung cancer screening programs. So let's stop for a minute and think, what does it require to have a lung cancer screening program? So one, you need a facility that has a CT scan that's available. You need to have a tech, you need to have providers to review these studies and provide counseling and smoking cessation counseling to patients. Without those variables or those elements, then you won't have an organized program. And also, patients will have to travel great distances to large medical centers that may have screening programs. So in rural areas and inner cities, there is a woeful lack of access to organized lung cancer screening programs. So things like mobile vans, mobile screening facilities would be a way to mitigate the disparities. So we need to improve access, and we need to have more organized lung cancer screening programs. And finally, insurance coverage has been a concern by many patients. Not all insurance carriers will cover lung cancer screening. CMS or Medicare does, but it requires a initial visit to discuss shared decision making and to help determine whether or not lung cancer screening would be beneficial. But it is covered in most cases. So these are some additional facilitators of acceptance. So education and outreach, which will come from public health officials, the United States government, Health and Human Services, to really make lung cancer screening as prevalent as mammography and also for colonoscopy for colon cancer screening. There will be need for policy and guideline changes in order to make this easier for patients to obtain. And that will require some grassroots efforts to really increase the awareness and to really highlight the benefits of lung cancer screening in certain high-risk populations. So in terms of future advancements, we heard earlier today that genetic and liquid biopsies might provide another avenue to make lung cancer screening more effective by detecting circulating tumor DNA in the blood to improve both the sensitivity and specificity of the screening studies. Also, artificial intelligence and machine learning can be utilized to screen CT scans to identify high-risk lung nodules to augment the analysis by radiologists. And also the actual imaging technology, which can measure, lung nodule tumor volume, will provide additional accuracy in determining which nodules are high risk. So in conclusion, lung cancer screening is important. There are two large randomized clinical trials which clearly identify a benefit in high-risk patients who are heavy smokers. There is an improvement in lung cancer specific survival when patients with high risk factors such as smoking and older age receive a low dose CT scan. They clearly have a benefit over patients who don't receive screening. So for future direction, we'll need to improve the uptake of lung cancer screening in these high risk populations and also reduce the false positive rate, overdiagnosis, and also mitigate radiation exposure, which is relatively small. So we do need a call to action. We need to create grassroots movements to increase the education and awareness of lung cancer screening for high-risk patients. We need to change the perception of harm that may be presented to patients by discussing this with our primary care physicians and really highlighting the results of the randomized clinical trials to really highlight the benefits to this high-risk patient population. And this will require changes in policies and also advocacy from certain medical centers and also medical groups. But we can do it. We've got a great tool. We can diagnose lung cancer at an early stage, and we should start doing this today. So thank you for your attention,